But it also comes with a lot of limitations. One of the major limitation is that it is a epicenter based ambiguity. We really don't know where is the G junction. There is inconsistency in defining what is G junction among endoscopists, pathologists and anatomists. And it is also based on what is the epicenter of the tumor rather than where it is arising from. It also restricts in that way in what surgery is to be undertaken in this classification, majorly in type 2. There is also poor preoperative accuracy, and when we see that there is only around 60% concordance between clinical and pathological classification, and when we look at type 2, it comes down to less than 50%. So this leads to misclassification and can also lead to suboptimal treatment protocols. There is also lack of integration with modern therapies, because these days we are talking about neoadjuvant therapy, which was discussed earlier, multimodal treatment, molecular profiling, which are not included in this particular classification. Can we improve this? Definitely we can. Recently, in September 2024, there was a study which was published. This is just a abstract as of now. We don't have the full paper, wherein Dr. Fonseca has created another modified system wherein they have described 6 subtypes. And this is basically based on 3 endoscopic measurements of the tumor. The G junction landmark is measured, the proximal extent of the tumor is measured, and the distal extent of the tumor is measured. The S1 is purely esophageal, S1 and 2, okay. S1 is esophageal involvement more than 4 centimeter. S1 and 2 is between 1 and 4 centimeter of esophageal involvement. In one, patient undergoes transthoracic esophagectomy. In 1 and 2, it is transhiatal esophagectomy. In S2, the esophageal involvement between 0 and 1 centimeter, patient can either go for transhiatal or extended total gastrectomy. Tumor at 0 centimeter, patient will undergo extended total gastrectomy. Between S2, 3, esophageal involvement 0 to 1 centimeter, either transhiatal esophagectomy or extended total esophagectomy. And patients with S3 will go for extended total gastrectomy. And for large tumors which cross across 1, 2, and 3, it is transhiatal esophagectomy and total gastrectomy. And they have shown that with this kind of classification, they have better R0 resections. Next, coming to EG junction, how do we describe EG junction? The Japanese have described EG junction based on 4 criteria. If it is endoscopy, the distal end of the longitudinal palisading small vessels is taken as G junction. The horizontal level of angle of his on barium meal is taken as G junction. And the proximal end of longitudinal folds of the greater curvature of the stomach shown on endoscopy or barium meal is to be taken as G junction. And the, if it is a pathologist who is seeing the level of macroscopic caliber change in the resected esophagus and stomach.